So I do encourage, if there's any questions, please submit it in the chat box and Emily will answer it real time. The presentation, we have a lot of information to get through. So I do plan on having some time at the end for live questions, but we may not get to all the questions. So if that's the case, we will include a separate PDF handout with the questions and answers in our follow-up email along with the presentation. All right, so these are some of our learning objectives. First, kind of looking at the mechanism behind the mRNA vaccine, looking at the two studies for the currently approved emergency use approved products from both Pfizer and Moderna, looking at the similarities and differences between the two vaccines approved under the EUA, and then also kind of briefly touching on the administration recommendations and the safety monitoring aspects. So this is just a brief review timeline. So back in December 2019, seems like really long ago, but not really. We have identified the first case of COVID-19 in Wuhan, China. The first case came shortly after into the US, the month later, and then the pandemic was declared by the World Health Organization in March. So fast forward for in a few months, the FDA granted the first emergency use authorization for the Pfizer vaccine in the US for people ages 16 and plus on December 11th. And then shortly, a few days after that, we saw our first US patient being our healthcare provider receiving the Pfizer vaccine. And Moderna is a second COVID vaccine that was approved for EUA through the FDA on December 18th. So the beginning of this week, data from MDH, so MDH has been keeping track of how many doses of vaccines that have been distributed, also doses that have been given and administered to currently is healthcare staff and also people in long-term care facilities. So as of the beginning of this week, 396,000 plus doses of vaccines have been distributed throughout all of Minnesota. 144,000 people have received at least one dose of the vaccine, and a little over 7,000 people have completed their 2-dose series. So that is a lot of people that have been vaccinated with showing some good outcomes with our vaccination efforts. So before moving into talking about the two vaccines themselves, I do want to touch base about the science behind the vaccine. First, with the science behind the virus infects our body. So the SARS-CoV-2, or the severe acute respiratory syndrome coronavirus, it is a novel zoonotic virus. So it usually spreads from animal to human. It utilizes the spike protein to bind the human angiotensin converting enzyme 2, which is HACE2, or the human ACE2 receptor, and it binds that to gain entry into the cell. And then once it gets into your cell, it multiplies to infect the host's body, essentially. So this is one of the key areas in drug development to inhibit that binding, to decrease the effects from the virus. And note that ACE2 receptor, it is a homology to the ACE that acts on several substrates in the angiotensin system, but the function and the active domain of the ACE2, it's not the same as our current ACE inhibitors, like our the medications that are approved for hypertension. So those medications do not inhibit or interact with that ACE2 receptor. So they have not been proven to help to decrease the viral spread. So once this virus gets into your body, to the cell, it replicates, and your body's natural immune response to do is to fight anything foreign that comes and attacks those viruses. Some of that gets destroyed, and then eventually leading to the production of the antibodies and memory cells. So for those people who have had COVID, they do have these antibodies that may provide some protection if you are to encounter the virus again. However, it is unknown how much and protection you have or how long it will last you. But for those people whose immune response is lacking, this process does not work effectively. So it allows the virus to essentially overwhelm your system. So that's why we see a whole range of infection, of COVID-19 infection, from asymptomatic mild disease to pneumonia to multi-organ failure and eventually death. So the mRNA vaccine technology takes advantage of that process that your cells use to make proteins in order to trigger an immune response, thus creating those antibodies in the memory cells that I mentioned in the previous slide. The mRNA acts as a blueprint for all the protein synthesis in your body. So from the vaccine, the mRNA is enclosed in what is called this lipid nanoparticle, or LNP, and that acts as a vehicle to help transport the mRNA into the cell. Like in the previous image, once the mRNA gets into your cell, it creates copies of that spike protein that's essential for the entry. And of course, your body sees that. They see that it's something foreign. They see the foreign spike protein, and then your body mounts that immune response to destroy it, thus creating that memory cell, that defense that we need. So that when you do encounter that real virus, the SARS-CoV-2 virus in the future, with that same spike protein, you already have the defenses in line to quickly destroy that virus. Here's another image of what I just explained, kind of the entry into the cell and creating that memory, that defense mechanism that we talked about. And of course, the safety has been the primary concern of the FDA since day one. There are some inherent safety features of the vaccine itself. First is the mRNA does not replicate. There's no codes, or there's no ability for that mRNA to go and replicate inside your body. It does not integrate into your DNA. You only receive a few copies from the vaccine versus over 200,000 copies of cellular mRNA. And it remains in the cytoplasm until it's eliminated naturally by the mRNA decay process. So in order to alter your DNA, it needs to get into the nucleus and be reverse transcribed, which it cannot get into your nucleus. There's no signals, there's no mechanisms for it to be reverse transcribed. The manufacturing process is cell-free and contains no human, fetal, or animal egg products, no preservatives, no adjuvants. The mRNA and the lipid nanoparticles, it only remains in your system for about 1 day. So that allows enough time for your body to utilize that to create that spike protein, but then it's quickly removed from your body. So both of the Pfizer and the Moderna vaccine is currently utilizing this technology to fight back against COVID. Before we get into talking about the trials, so we'll discuss briefly what exactly is EUA, or Emergency Use Authorization. The EUA is a process to facilitate the availability and use of a new treatment or test, or of an existing one for a new indication. The authorizations are only in effect for as long as there's a public health emergency. And after that, in order to remain on the market, the treatment or the test must have a full FDA approval to do so. The goal of the EUA is to provide access to medical products that may potentially be used when there's no other approved options. One of the minimum requirements is that the known and potential benefits outweighs the known risk, using the best available evidence currently. And we see historically EUAs have been granted for Tamiflu back in H1N1 for infants, and there are multiple EUAs that have been approved as well for other COVID-related treatments and tests. So for the COVID vaccine, the FDA, one of the requirements for granting the EUA is that the studies have to have at least 30,000 participants, and they have to have been followed for a total of or at least 2 months, which we'll see shortly that the 2 vaccines did complete. So going to the first vaccine that was approved by the FDA for emergency use authorization. So this is from Pfizer BioNTech. This is approved for individuals 16 years of age and older. So this is just a brief timeline of their production process. So as you can see, this vaccine did meet the FDA requirement for the participant number. They had about 44,000, and then the duration of phase 3 trial of at least 2 months. Note for both vaccine, the researchers went through the same phases of development and testing as any other medication or vaccine that is on track for FDA approval. This was just a very accelerated process, but I want to emphasize that there were no steps that were skipped in this FDA review process. I know there is a lot of information on this slide, but I just want to highlight some key facts from the Pfizer trial. First, it is a randomized, double-blind, placebo-controlled study that was conducted worldwide in multiple countries. They had over 43,000 participants in the study, and they looked at the incidence of COVID-19 in participants without prior infection, as well as those that had prior infection. They included anyone over the age of 12 years old that was able to give consent. And they also had people with stable chronic diseases like HIV, Hep C, Hep B included in the study. Some of the exclusions were anyone with a previous diagnosis of COVID-19 before the first dose, people that were immunocompromised, and women that are pregnant or breastfeeding were not included. For the efficacy analysis, the Pfizer vaccine was given 21 days apart. And before each dose was given, the participants were swabbed for COVID before each of the dose 1 and dose 2. And they were also tested for antibodies too, to see if they've their history of prior infection. So if at any time after the participants received the first dose and they displayed a potential COVID-19 symptom, they were scheduled for a telehealth, a virtual visit or an in-person visit. And then they are also administered a nasal swab to check for COVID. As you can see here, this is a table of the demographics, so the population that were enrolled into the Pfizer study. There are similar ratios of male to female. The age of vaccination, the median age was 52, but it ranged from participants from age 12 to all the way to 89. It was mostly a white population, a lot from the US that was enrolled, but there was a good portion of people that also had comorbidities, obesity, diabetes, pulmonary disease, along with the HIV, Hep C, and Hep B that I talked about recently. So in the per protocol analysis, efficacy analysis, about 37,000 participants that they submitted in mid-November for FDA consideration. The efficacy in preventing confirmed COVID-19 occurring at least 7 days after receiving the second dose of vaccine, they found was 95%. In the vaccine group, there were 8 cases of COVID-19 versus in the placebo group, which was a saline placebo, there were 162 COVID cases. They saw that there were similar efficacies across age, gender, racial, and ethnic groups, even participants with other comorbidities as well. So in participants without evidence of prior infection, the vaccine efficacy, again, 7 days after dose 2 was about 95%. For people with or without evidence of prior infection, it was 94.6%, so very similar. There is, however, limited data on the prevention of hospitalization or death from looking at the high efficacy rate, but we can infer that with the high efficacy, eventually hospitalization and death potentially could be prevented. And also, while there is limited data, do suggest that previously infected individuals can still be at risk of COVID-19 reinfection and could also benefit from the vaccination as well. So here's the cumulative incidence curves for all the available efficacy population after dose 1. COVID-19 disease onset appears to occur similarly for both the vaccine and placebo group until approximately 14 days after dose 1. So at which time you see the curves kind of diverge with more cases in the placebo group. And there does not appear to be any evidence of any waning protection during the follow-up time of the 2 months during the whole trial. So that, again, this is showing really good efficacy outcome for the vaccine. As for the study, the safety analysis, again, the active surveillance begins after dose 1. And any symptom of COVID-19 triggered for that participant to have an appointment and also a nasal swab. All participants were also followed up in 1 month after dose 2, and also they plan for a 6-month follow-up for any serious adverse effects. So data from the 2 months follow-up after the 2nd dose, the most common was injection site reaction, the pain, soreness, the fatigue, headache, and muscle pain. Note there were 6 deaths total in the whole study of 43,000 participants. There are 2 deaths in the vaccine group and 4 deaths in the placebo group. The researchers saw that all the deaths represents events that occur in the general population of the age groups that where they occurred, so at similar rates. So they concluded that it was not due to the vaccine. Here's some graphics on the post-vaccination reactions. And you can see from the top picture is from 7 days from dose 1. The bottom picture is 7 days from dose 2. So in all of the little bars, you see that the reactions are more common after receiving the 2nd dose, which is what we're hearing from our fellow colleagues that have received their 2nd dose too, that they are experiencing a more pronounced vaccine reaction. And this graph, it breaks it down to the 7 days post dose 2, and it breaks it down by age group. So the top one has people that are 16 to 55-year-olds. The bottom one have people that are greater than 55-year-olds. So between 1 to 7 days post-dose, the systemic events they occur with a median onset of 1 to 2 days after each dose, with a median duration of 1 to 2 days as well. And you can also see there's a slight difference, a slight decrease or less occurrence in people that are older. So the bar graphs are a little smaller for those that are greater than 55-year-olds. So post EUA approval, Pfizer plans to offer the vaccine to all their participants that 16 years and older who received the placebo originally, and they will continue to follow up with them for the total of 24 months as proposed. Right now, there's no data on long-term efficacy or effects of COVID-19 disease in people who are infected despite vaccination. And then there's also no data on immunocompromised individuals or people that are pregnant or breastfeeding. So that is their plan also, is to continue to study in those populations, continue to study whether or not there's a booster dose requirement, and also looking at temperature storage, whether the vaccine can be stable outside of the ultra cold temperature requirement. We'll touch base on the storage requirement a little later too. So the next vaccine I'll go through is the Moderna vaccine. That's again also authorized for EUA. This is for individuals ages 18 years of age and older. Very similar table, again, highlighting some of the trial design. It is also a randomized, double-blind, placebo-controlled. It's a multi-center trial that was across 99 sites in the US. They had over 30,000 participants, and of note, a little more than 7,000 were healthcare workers in this trial. They looked at the prevention of COVID-19 that was occurring at least 14 days after dose number 2 in people with a negative infection at baseline. The participants were followed for any solicited adverse reactions for 7 days after each dose. So you get very similar design to Pfizer. And then they also looked at any unsolicited adverse events for 28 days after each dose. So again, like Pfizer, if the participants had any symptoms of COVID, that prompted to have an appointment, telehealth appointment, and also a nasal swab. Then for Moderna, they specified the symptoms have to be at least, so the participants have to present with at least 2 of the following symptoms, whether it's fever, chills, myalgia, headache, sore throat, or a loss of taste or smell, or one of the following symptoms is cough, shortness of breath, pneumonia, so more severe symptom, and then they'll be given the nasal swab. The inclusion for the study, so people that are 18 years and older, so hence there's a difference in that age approval that we see. They also had adults with stable comorbid conditions, so very similar to Pfizer. Exclusion, again, very similar to Pfizer, history of COVID-19 infection, SARS-CoV-2 infection, if they're pregnant or breastfeeding, or they're immunocompromised. So the participants in the Moderna study, they were stratified in groups by age and health risk into the one of 3 groups. So the first group is people that are 18 to 65, and they're not at risk for severe COVID-19 infection, so no comorbid conditions. The second group is people 18 to 65, and they are at risk for severe COVID-19 infection. Then the third group is people that are older than 65 with or without comorbid conditions. And you can see that the bottom 2 groups there, about 42% of the study population. So they had a good show rate, essentially. In here, this is their breakdown of their participants. So you can see Moderna, so the left column, the mRNA 127, that is the Moderna vaccine versus the placebo. So the study included healthcare workers and also a whole slew of essential workers. So this is their study timeline. So very similar to Pfizer. The active surveillance began after dose number 1, and then also before each dose, a nasal swab, and then a laboratory evaluation looking at complete blood count, liver function, kidney function were conducted in the patients. And then they also had a scheduled follow-up visit occurred 1 month after post-dose number 2. So again, very similar timeline and study design as the Pfizer vaccine. Here, I want to highlight some of the participant demographic characteristics. So between the female and male, very similar amount of each groups. The age, so we have a higher group of 18 to 65-year-olds in the vaccine group versus 65 and older. For race and ethnicity, non-Hispanic white, that consisted of 63.6% in the vaccine group versus communities of color were about 36%. And again, the occupational risk with health workers, there's about 25% of healthcare workers that were included in the studies. So looking at the vaccine efficacy for the prevention of COVID-19 after 14 days post-dose number 2, they saw overall efficacy was 94.1%. So very similar to Pfizer, you see a slightly lower rate in the older population for the vaccine efficacy. But the overall, again, was 94.1%. They did also look at secondary endpoints of preventing severe COVID-19 that required hospitalization. And again, additional analysis were done to assess efficacy against COVID after the first dose of the vaccine. So there appears to be some protection against COVID-19 disease following one dose. The preliminary data showed about 80.2% vaccine efficacy. But the amount of data does not provide sufficient information about longer term protection beyond the 28 days after that single dose. And then there is some data that they're working on too on post-dose number 1 for asymptomatic carriers, and then how much that that prevents or the asymptomatic carriers. So this curve is similar to the Pfizer curve. So you see that at 14 days post-dose 1 is where you start to see the curves kind of diverge, and you see that the efficacy of the vaccine. So for the safety analysis, phase 3 study included, what's neat about Moderna is their phase 3 study included an independent data and safety monitoring board chartered by the National Institute of Health. So they have active surveillance throughout the study, daily virtual visits for those with COVID-19 symptoms. They're also keeping an e-diary 7 days after each dose. And then any serious adverse effects or any medically attended adverse effects were also logged in the study. All right, for the safety analysis, so the participants were followed for a median of 9 weeks after their second dose. So again, very similar to Pfizer, the most common side effects are the injection site pain, the fatigue, the headache, the muscle pain. Again, similar to Pfizer, you see these post-injection reactions. They are less frequent in people that were 65 and older. And then for Moderna, they also talked about throughout the safety follow-up period, there were 3 reports of facial paralysis, so Bell's palsy in the vaccine group and 1 in the placebo group. So the currently available information is not sufficient to determine a causal relationship with the vaccine. Again, the safety profile of the Moderna vaccine was generally similar across all age groups, genders, ethnic and racial groups, even participants with or without medical comorbidities. And as of the beginning of December, there were 13 deaths reported in the Moderna study, so 6 in the vaccine and 7 in the placebo group. So the event rates are very similar to the general population. So there's no, the researchers did not see any relationship between that and the vaccine. Here are some graphics about the local adverse effects and also the systemic adverse effects. And you can see between dose 1 and dose 2, again, it's more frequent after dose number 2. You see the bar graph increase a little bit. And again, it's very similar to Pfizer. So with Moderna, very similar to Pfizer again, they will be vaccinating people in the priority groups and following up with them 24 months after that dose. There is, so the continued studies to assess, they are planning on doing that for pregnancy lactation and immunosuppression. There is some preliminary data for pregnancy in rats of the vaccines given prior to gestation and during gestation. And that data showed that there was no adverse effects on female reproduction, fetal development, or any postnatal development. So kind of looking back at both trials, the data is limited to assess the effects of the vaccine in preventing asymptomatic infection as measured by detection of the virus or else detection of the antibodies against non-vaccine antigens that would indicate that the person had the infection rather than an immune response induced by the vaccine. And then how long that protection will last is still a question for both Pfizer and Moderna. And in a recent study, Moderna found that 3 months after the second dose, volunteers were still making high levels of antibodies. And again, we still don't know yet what levels are needed to maintain the immunity. So more time, more research about requirement for booster dose will definitely be needed. So kind of a little summary of both the Pfizer and Moderna vaccine. Both studies met the FDA requirements for participants of 30,000 or more, followed for at least 2 months. The efficacy rate is between 94 to 95 if the participant received both doses as directed. Common side effects are the injection site pain, fatigue, headache, and muscle pain. And again, the ongoing studies for children, lactating, pregnant women, immunocompromised, and then longer term safety and efficacy. I'm going to jump into some general vaccine information for both Pfizer and Moderna, but I want to refer you to looking at the EUA fact sheet for more detailed and specific instructions on storage and preparation. I will highlight some differences here. The age indication is different, so 16 plus for Pfizer, 18 plus for Moderna, which again is due to the study population. The volume is different, so 0.3 mils for Pfizer, 0.5 mils for Moderna. The frequency is also different, so 21 days for Pfizer, 28 days for Moderna. There is a 4-day grace period that people can receive the vaccine earlier if need to. And then Pfizer vaccine does require reconstitution and storage in ultra cold freezer or in a thermal shipper with dry ice. And for both vaccines, with each new introduction into a different temperature range, so like taking the vaccine from frozen to fridge to room temperature, the beyond use date is different and it must be tracked. And both vaccines are preservative free and it does not contain any rubber in the vial stopper. And I want to reiterate too, as seen from the studies, that both doses are necessary for protection because efficacy of the single dose has not been evaluated. The vaccines are not interchangeable between Pfizer and Moderna. So there are no studies in the mixed series. So if you start the series with one product, you need to complete that with the same product. If for whatever reason and inadvertently you are given a Pfizer vaccine and then a Moderna vaccine product, no additional doses of either vaccine is recommended at this time. It should be separated from other vaccines at a minimum of 14 days. Again, there's no studies to look at co-administration of other vaccinations. But if they're inadvertently administered with another vaccine within the 14 days, you do not need to repeat doses of either vaccine. Other vaccine recipient considerations, vaccination should be offered to person regardless of history of prior symptomatic or asymptomatic infection. You see data from the phase 2 and 3 trials that suggest that vaccination is safe and also effective in these people. There's no need for any viral or serologic testing before receiving the dose. There's no minimal interval between infection and vaccination, but for those that are currently ill, they should defer vaccination until after their illness or in isolation. There's currently no data on safety or efficacy of COVID-19 vaccination in persons who have received monoclonal antibody or convalescent plasma as part of COVID treatment. But we do have information that based on estimated half-life of the therapy and evidence suggesting that reinfection is uncommon within the 90 days of initial infection. People with any known exposure, they should still receive the vaccine, but after an adequate isolation period. Other special populations, so people that have underlying medical conditions, as we just saw both in the trials, that There were similar safety and efficacy profiles in persons with and without comorbid conditions. People that are immunocompromised, so they can receive the vaccine if there are no contraindications, but providers should counsel on the unknown vaccine safety and efficacy profiles of both vaccines. There is a potential for reduced immune response in this population, and they do need to continue to follow all current public health guidance, like wearing masks and washing hands, which everyone, even if you're not immunocompromised, should still follow after receiving both doses. For people that are pregnant and breastfeeding, so per guidance from the American College of Obstetricians and Gynecologists, if a woman is part of a group, like healthcare personnel, who is recommended to receive the vaccine and she's pregnant or breastfeeding or lactating, she may choose to be vaccinated. So I listed some considerations for discussion between pregnant patients and breastfeeding patients with the providers too. Absolute contraindications to receiving the mRNA COVID-19 vaccine is any severe allergic reaction, so anaphylaxis to a previous dose of mRNA vaccine or to any of its components. And then you will see the precautions here. I'm gonna go to the next slide. All right, so the ingredients included in both the vaccine, it's listed both in the EUA fact sheet. So again, there's no preservatives, no antibiotics, no adjuvants, and then all the components are also rapidly cleared in the body. I want to note that there is PEG, so polyethylene glycol, in both of the vaccines. So this is a primary active ingredient in osmotic laxatives or bowel preparations for colonoscopy procedures. It's also used as an inactive ingredient in many medications. There is a cross-reactive hypersensitivity between PEG and polysorbates, which are, again, also used in productions of other vaccines and medications. So if you had a history of severe anaphylaxis, allergic reaction to any of these components, we recommend you are contraindicated from receiving the COVID vaccine. Briefly touch on what is not in the vaccine. So the manufacturing process is cell-free, contains no human or animal products, preservatives, adjuvants, so no pork, gelatin, fetal cells, microchips. It does not contain any form, shape of the virus, live, attenuated, or inactivated, and no egg. So I want to briefly review on how to distinguish allergic reactions from other types of reactions. As I talked about in the contraindication, if you've had an anaphylaxis to a previous dose of COVID vaccine, what does that look like, and how can you tell that you did have an anaphylaxis to the COVID vaccine? So there are three. So the immediate allergic reaction is what I want to focus on, where it occurs within 15 to 30 minutes of vaccination. You're essentially feeling a feeling of impending doom, where you're flushing, angioedema, confusion, disorientation, hypotension, tachycardia, shortness of breath, nausea, vomiting, abdominal cramps, or diarrhea. And so all those potentially are reactions that indicate an anaphylaxis to the vaccine. So if, of course, talking to medical provider, if you do have those symptoms after the vaccination, you most likely will be treated and triaged and hospitalized. And that if that was the case, then you should not receive a second dose of the COVID-19 vaccine. The other columns talk about the vasovagal reaction, so more of the fainting that could be triggered by site of the needle. So very similar, I'll have you take a look at that afterward and send it out to very similar signs and symptoms as the anaphylaxis. But so it is very important to talk through it with the medical professional. Once you receive the vaccine, you are monitored for these symptoms as well. And then the last column talks about the vaccine side effects that are the local and systemic side effects that we're seeing in participants in the trials, but also if you have asked people that have received the vaccine, they may or may not have one or more of these symptoms after their receiving of the vaccine. So this algorithm is published by the CDC. It kind of goes through the different conditions and allergies and whether or not the person should be given the vaccination, or there's a precaution, or there's a contraindication. So again, the contraindication is for anyone with a severe allergic anaphylaxis to a previous dose of the vaccine or any of their ingredients to the vaccine. So that you should not give the vaccine to those people. But everything else is either a precaution or you can proceed with the vaccination. And then observe for between 15 to 30 minutes. So for anyone with any history of anaphylaxis due to any other cause, whether that's another medication, another food, or environmental product, you should be observed for 30 minutes versus the regular 15 minutes. Here's a list of things that are neither contraindications nor precautions to receiving the vaccine. So any history of allergic reactions not related to vaccines or injectable therapies, such as food, pet dander, venom, environment, oral medications, latex, eggs, gelatin, you can still receive the vaccine. There is a really robust safety monitoring post-vaccination that CDC has established. So we have the VAERS system, the Vaccine Adverse Event Reporting System, that has been in place and established for many years. So that's a reporting system for anyone that see potentially there was a vaccination error or any serious adverse events after vaccination. What's new is the V-Safe system. So it's a new smartphone-based app that uses a text messaging and web survey from the CDC to check in with the vaccine recipients after they receive their vaccination. The system also provides telephone follow-up to anyone who reports any medically significant adverse events. Other brief patient counseling for vaccination. So before vaccine, make sure you're counseling the patient on any local or systemic post-vaccination symptoms. And make sure you counsel that they should complete the series, even if they develop some post-vaccination symptoms that are not contraindication, i.e. not anaphylaxis. After receiving the vaccine, again, counsel the patient that the protection from the vaccine is not immediate. It will take 1 to 2 weeks after the second dose to be considered fully vaccinated. And as always, no vaccine or medication is 100% effective. So continue to follow public health guidance to protect yourself. The patient may take antipyretic or analgesic for treatment of post-vaccination symptoms, but they don't recommend to take it as a prophylaxis measure. So when they have the symptoms, they can take Tylenol, ibuprofen, for instance. And here are some other resources for healthcare providers with questions regarding COVID-19 vaccines. CDC, MDH has a lot of great resources along with Pfizer, Moderna. And then for more information on the studies themselves, the FDA has a lot of information from their meetings. All right, thank you for hanging on. I know we have a little bit of time for questions. I think Emily has been answering the questions real time. So Emily, if there's any questions that you want to do real time right now, we can do that.
We've had a couple just come in the last few minutes. One is, how much is the cost for people who don't have medical insurance?
Good question. So the vaccine, it is offered, given to clinics, all sites, free of charge. So there's no cost for anyone. And if people have insurance, the clinic that's administering the vaccine or the hospital that's administering the vaccine may charge an administration fee. But if the administration fee is not covered by the patient's insurance or the patient is uninsured, then that is waived too. So essentially anyone and everyone can receive it and it will be zero out of pocket.
All right, and the other one still left in here is, well, now we've got a couple. So in the studies, did the vaccine prevent asymptomatic shedding?
They did not look at that in the studies. So in both studies, only when the participants had a symptom of COVID, potentially COVID-19, that is when the telehealth visit is triggered, and then they receive a nasal swab. So they weren't, swabbing people on a daily basis to see if they had asymptomatic infection.
And then last one in here for now is, how is COOT going to distribute the vaccines?
Yeah, that is a good question. We are working on kind of a process, first definitely to outreach to our patients, and then how we're going to get the vaccine from frozen to thaw, and then also I want to say a big factor that we need to consider too is that observation period after receiving the vaccine. That it's not like receiving a flu vaccine where you just give it and then people go. So we'll have to kind of looking at spacing to allow for that 15 to 30-minute observation.
Yeah. We have some thank yous in the Q&A, and another question, does the doctor have to put an order in for the vaccine?
Yeah, so that the MDH has published a vaccine protocol for nursing and staff too. So depending on each clinic or site, the medical director can decide to sign that protocol that will allow for the support staff to order the vaccine and administer, and pending that the patient meets all the criteria and they're not contraindicated.
That's it in there for now.
All right. Well, thank you everyone for attending. And again, we welcome other questions. If you think of other questions, feel free to email it to myself or email it to Christina, and she'll get me the question.